Namaste, myself Triveni Khurana, Assistant Professor, Faculty Physiotherapy and Diagnostics, JVN, Rajasthan. Today we are going to discuss about facial nerve palsy. Facial nerve, the seventh cranial nerve palsy, is often idiopathic, formally called Bell's palsy. Idiopathic facial nerve palsy is sudden unilateral peripheral nerve facial nerve palsy. Symptoms are hemifacial paralysis of the upper and lower face. Tests involve X-ray, serum, angiotensin converting enzyme. Test for Lyme disease, serum glucose are done to diagnose treatable cause. Treatment may include lubrication of eye, intermittent use of an eye patch, or for idiopathic facial nerve palsy, corticosteroids. Historically, Bell's palsy was thought to be idiopathic. However, facial nerve palsy is now considered as a clinical syndrome with its own differential diagnosis. About half of the cases of facial nerves are idiopathic. Mechanism for what was previously thought to be idiopathic facial nerve palsy is presumably swelling of the facial nerve due to an immune or viral disorder. Current evidence suggests that common viral causes are herpes simplex and herpes zoster. Other includes cytomegalovirus, adenovirus, coxsackie virus, Epstein-Barr, mumps, rubella, influenza B virus. Swollen nerve is maximally compressed as it passes through labyrinthine portion of the facial canal, resulting in ischemia and paresis. Facial nerve muscle are innervated peripherally by ipsilateral seventh cranial nerve and supracentrally by supranuclear innervation by the contralateral cerebral cortex. Central innervation tends to be bilateral for the upper face and unilateral for the lower face. As a result, both central and peripheral lesions tend to paralyze the lower face. However, peripheral lesions tend to affect the upper face more than central lesions. Pain behind ear often precedes facial paralysis in idiopathic facial nerve palsy. Paralysis, often with complete paralysis, develops within hours and is usually maximal within 48 to 72 hours. Patients may report a numb or heavy feeling in the face. The affected side becomes flat and expressionless. Ability to wrinkle the forehead, blink, grimace is limited or absent. In severe cases, the palpebral fissure widens and the eyes does not close, often irritating the conjunctiva and drying the cornea. Sensory examination is normal, but the external auditory canal and a small patch behind the ear may be painful to the touch. If nerve lesion is proximal to the geniculate ganglion, salivation, taste, and lacrimation may be impaired, and hyperacusis may be present. It is diagnosed by clinical evaluation, CT, serum angiotensin converting enzyme, MRI, and other testing if indicated by clinical finding. Facial nerve palsy can be distinguished from a central facial nerve lesion due to semi-stroke or tumor, which causes weakness primarily of the lower face, sparing the forehead muscle and allowing patient to wrinkle their forehead. Also, patients with central lesions can usually furrow their brow and close their eyes tightly. Usually, clinicians can also distinguish idiopathic facial nerve palsy from the other disorders that causes peripheral facial nerve palsy based on their characteristic symptoms and signs. In idiopathic nerve palsy, MRI may show contrast enhancement of facial nerve at and near geniculate ganglion or along the entire course of the nerve. However, its enhancement may reflect other causes such as meningeal tumor. If the paralysis progresses over weeks to months, likelihood of tumor compressing the facial nerve increases. MRI can also help exclude other structural disorders causing facial nerve palsy. CT, usually negative in Bell's palsy, is done if a fracture is suspected or MRI is not immediately available and stroke is possible. In idiopathic facial nerve palsy, the extent of nerve damage determines outcome. If some function remains, full recovery typically occurs within several months. Now, conduction studies and EMG are done to help predict outcomes. The likelihood of complete recovery after total paralysis is 90% if no branches in the face retain normal excitability to supramaximal electrical stimulation, and is only about 20% if electrical excitability is absent. Regrowth of nerve fibers may be misdirected, innervating lower facial muscles with periocular fibers and vice versa. The result is contraction of unexpected muscles during voluntary facial movement, that is synchynesia, or crocodile tears during salivation. Chronic disuse of the facial muscle may lead to contractures. Now the treatment, it involves protection of cornea, corticosteroids for idiopathic facial nerve palsy. Corneal drying must be prevented by frequent use of natural tears, isotonic saline, methyl cellulose drops, and by intermittent use of tape or patch to help close the eyes, particularly during sleep. Tarsorrhaphy is occasionally required. In idiopathic facial nerve palsy, corticosteroids, if begun within 48 hours after onset, result in faster and more complete recovery. Prednisone 60 to 80 mg orally once a day is given for 1 week, then decreased gradually over the second week. Antiviral drugs effective against herpes simplex virus. Facial functions are multidimensional, serving emotional, social, physical aspect of a person's health. Primary functions of the face include displaying effectiveness, emotion, identifying and communicating with other human beings. Different portions of the face also play a major role in eye protection, eating, drinking, and speech. In addition, facial recognition and the perception of facial attractiveness facilitate communicating among people by influencing interpersonal attraction. These human attributes are necessary to establish and maintain intimate interpersonal relationship and to preserve effective social interactions. Therefore, when a person experiences facial paralysis, the concerns encountered also are multidimensional. These concerns can range from emotional distress to physical problems such as leaking of food from mouth, difficulty in communication, and consequent attenuation of social interactions. An impaired ability to express context-specific emotions can be detrimental to a person's sense of emotional well-being and the ability to establish and maintain interpersonal relationships. Such impairments can create a sense of shame and fear of rejection and being misunderstood or misjudged by others. Condescending reaction by others to the resultant facial unattractiveness from facial asymmetry can lead to low self-esteem and unfavorable body image for people with facial paralysis. In addition, pain and irritation of eye, unanticipated pronunciation errors while speaking, leaking of fluid and food while drinking and eating, especially in a social context, may significantly interfere with daily activities and cause considerable physical and psychological distress to people with facial paralysis. The basic assumption underlying all these intervention strategies is that passive treatments include electrical stimulation, active exercises such as facial neuromuscular re-education, mime therapy, improvement in one dimension of facial dysfunction will automatically lead to overall improvement in others. Because facial functions are complex and any intervention strategy aimed at having a profound impact on the recovery of people with facial paralysis must address a multidimensional nature. Let's discuss a case. The purpose of case report is to describe the development of functional training program and demonstrate the use of intervention. Multidimensional approach of functional training program addressing expression of emotion, altered body image, self-esteem, negative coping strategies would be appropriate intervention strategy for the complex problem. Intervention need not be limited to those described in the report. Framework of the functional training program, clinicians can develop specific strategies that are relevant to the patient's contextual factors, including personal, social, and cultural. Examination of the effects of functional training program with more rigorous patient education typically includes information about the anatomy of the facial nerve, facial musculature, synkinesis, as well as the recovery process. Approach may be inadequate when a patient's primary concern arises from the disabling psychosocial consequences of facial paralysis, including low self-esteem, social isolation, and altered emotional well-being. During the post-treatment, the patient reported that family members had identified noticeable improvement in face. In Indian culture, it is customary for a woman to wear jewelry, especially during social occasions, as an important indicator that she is feeling good about herself. The patient's renewed interest in wearing jewelry and makeup helped reassure us that her perception of her facial attractiveness and body image had improved. In addition, we noted that she started removing her veil after entering our clinic, something she previously had been reluctant to do. When asked about his new behavior, she replied that she removed her veil more frequently now. Such behavioral transformations clearly indicate improved social interaction skills, self-perception of body image, and self-esteem confidence also. Function training component program encourages and provide opportunity to express context-specific variable emotions within patient's natural environment and involves tasks that facilitate other facial motor functions within environment, such as raising mouth and spitting out water, or playing games such as blowing bubble. Intervention strategies such as watching movie, television program, humorous video, discussing them during treatment sessions, sharing funny incident or jokes with friends provide more opportunity to express felt emotion within the real world context. While watching movie, people tend to mimic emotional content or react to emotion displayed in the scene being watched, and this behavior may facilitate spontaneous expression of emotions. During narrative discussion, expression involve movement of the corner of the lip and wrinkling of skin at the outer edge of the affected eye, movements that began unable to produce voluntarily. Complementary exercises also might have contributed to change observed on physical function subscale, and that is improvement in the ability to drink and eat without leaking of fluid and food from the mouth and inability to close the eyes. Thank you.